In this lecture, we are going to talk about the physiology of the heart. First, we're going to go over a little bit about the cardiac muscle, its structure and function, and then relate that to the electrical conduction system of the heart before going into ECGs and finally go into some of the parameters which control how much blood is pumping through the heart. So cardiac muscle is similar to skeletal muscle in that it's striated, but unlike skeletal muscle, it is relatively short, has branches, as you can see on this right here. You can see it's branching. It's usually uninucleate, so one nucleus per cell. And then one of the key things is that it is going to be interconnected. So that's what these intercalated discs, which you are seeing right here, represent. Those intercalated discs are going to be where you have dark staining junctions on the plasma membrane. There's two kinds of connections here. One is the desmosomes, which are going to hold them very tightly together. And the other is the gap or communicating junctions, which is going to allow for the flow of ions and essentially allow the myocardium to behave as a single unit instead of each cell functioning each individually. Another way that the cardiac muscle differs from the skeletal muscle has to do with the sarcoplasmic reticulum. So it was playing a major function in skeletal muscle, but here you are also going to get some of the calcium from the extracellular space. Interspersed within the cardiac muscle cells of the heart, you have pacemaker cells. These are cells that are self-excitable, which is to say that they are autorhythmic. They're going to contract without having to have an impulse come in. Another difference has to do with the refractory period. So the refractory period of the heart is long, and it's nearly as long as the contraction, which is key in preventing the tetanus from happening. So where you could have contraction, the stimulus happening so fast that contraction basically just stays continuous in skeletal muscle, that's not going to happen in heart muscle, which is good because you want your heart to be able to relax so it can continue pumping blood. And then skeletal muscle can rely on both aerobic and anaerobic respiration, but cardiac muscle is going to be more dependent on aerobic respiration and therefore will have more mitochondria. All right, so two cell types in the heart. One is going to be the cardiac conductive cells. These are the cells that undergo this spontaneous depolarization. So normally you have a stable membrane potential when it comes to muscle cells, but in the case of these cardiac conductive cells, you do not. So it has an unstable resting potential. It goes about as low as -60, but it doesn't stay there like it would if it was a stable one. And then it's going to exhibit a slow depolarization that is spontaneous. This is known as the pre-potential or the pacemaker potential. This is due to the slow influx of sodium through leaky sodium channels. So the sodium leaks through here, and then it reaches this threshold. At this threshold, that is when you're going to have the voltage-gated calcium channels open, and calcium is going to start going in very rapidly, which leads to rapid depolarization. At the peak here now, those calcium channels are going to close, and potassium channels are going to open. And so potassium efflux from the cell is going to lead to repolarization as it leaves, and this is going to bring it down back to the low level before it undergoes this again, and the leaky sodium channels are going to let the ions in. All right, so this brings us to the other type of cells, the contractile cells of the cardiac tissue. So these actually do have a stable resting membrane potential. It differs based on whether these cells are found in the atrium or the ventricle. In the atria, it's -80 millivolts, while in the ventricle, it's about 90 millivolts. So there's a few things about this. So they are going to need an impulse to cause contraction. So that's what this initial upward tilt of this black line is representing. It's getting some nerve impulse. This is going to come from the pacemaker or conductive cells in most cases, although it can be altered by other factors. Then it's going to go until it hits a threshold. At threshold, you're going to have voltage gated sodium channels open up, and it's going to lead to a fast influx of sodium. Finally, you're going to reach a point where the sodium channels will close, and then calcium channels are going to open. Now, these are slow calcium channels, so they let calcium in, but not as fast as the sodium. So it leads to a kind of a plateau where the resting membrane potential, or the membrane potential, is going down, but very gradually. Then once it reaches a point, the slow calcium channels will close, allowing the voltage gated, and then the voltage gated potassium channels are going to open. This leads to repolarization that's much more rapid, and then that will end when the membrane potential goes back to the resting membrane potential, where the potassium channels will close. And then it would repeat this for another cycle. Now, this brings us to the refractory periods. So your absolute refractory period, remember, is when you can't get contraction to happen no matter what. That is going to happen initially because the cell cannot fire another action potential. This lasts about 200 milliseconds, and then your relative resting or relative refractory period, that is where another potential could be fired, but it's going to need to overcome the repolarization that's already happening, so it's unlikely to occur. This is going to last about 50 milliseconds. So together, the total refractory period is about 250 milliseconds. As I mentioned before, this long refractory period is essential because it prevents tetany. This ensures that the pumping is going to be rhythmic, that it'll allow the ventricles to fill before they contract again, and it will prevent lethal premature contractions. All right, so this brings us to where we actually find these different types of cells within the heart and what they're doing. So first of all, the electrical impulses are going to determine the rate at which a heart beats. And you have several different places where this can occur, but it starts at one particular place important, and that is going to be the sinoatrial node, or SA node. This is the node that is known as the pacemaker of the heart. It produces your normal sinus rhythm, and deviations from that is going to be due to generally neural input, or will be due to endocrine signals altering the contraction of the heart. So the sinoatrial node is going to be made up of the conducting cardiac cells, and they have the highest inherent depolarization rate. So the one with the highest depolarization rate is going to result in the pacemaking of the heart, and that's why it ends up being the pacemaker of the heart. So the impulse is going to spread throughout the atria, and it's also going to spread to the other atria. So it goes to the other atria through Bachmann's bundle. So this is going from the right to the left atrium, and then the internodal pathways are going to be what transmit it throughout the rest of the right atrium. the internodal pathways are going to converge, going to the atrioventricular node or AV node. Here you have a delay of the impulse. This delay is about 0.1 seconds. This is essential because it allows the atria to complete its contraction, because contraction is going to follow the impulse before the ventricles are going to start to contract. Now, it does have a normal impulse, normal conductive depolarization rate of about 50 impulses per minute. So this is slower than the SA node. It's still sufficient that if you have a blockage or something that prevents the SA node from transmitting to this, you can still get the heart beating at a regular rhythm, but it is generally slower than what you'd want. So the pacemaker of the SA node is generally going to rule over this, since this is slower. All right, the AV node is going to then transmit the signal from the atria to the ventricles via the bundle of His, or AV bundle. So it's also known as the AV bundle. It is the only electrical conduction connection between the atria and the atria and ventricles. When we talked about all those connecting junctions between cardiac cells, that doesn't happen in most cardiac cells between the atria and ventricles, but it does happen here, so that you can get that contraction happening. Then the contraction is going to move down here through the left and right bundle branches. So it moves down the ventricular septum of the heart, and then it's going to go back up to the sides of the heart via the Purkinje, via branches off of these onto the Purkinje fibers. So the contraction is actually going to follow as these go back up, which allows the heart to contract from the bottom and contract upward, driving contraction like you would get if you squeezed a toothpaste tube, and you'd squeeze from the bottom to make sure that the stuff is all going upward, where if you squeeze from the middle, you'd have some of it going upward, some of it going backward, and that would not be productive for a pumping heart. So these are the signals that lead to a normal normal pace of the heart, but you can have neural inputs that will alter this as well. So first of all, so this is normal up here, where you have the prepotential spontaneous depolarization, but you can alter this with either parasympathetic stimulation, which is going to result in slower depolarization, or with sympathetic stimulation, which will result in faster depolarization. So depending on whether it's the parasympathetic that is dominating or the sympathetic that is dominating, will affect whether the heart rate is going to be faster or slower than your normal resting spontaneous sinus rhythm. All right, these electrical signals then are going to produce what is known as an ECG or EKG. That stands for electrocardiogram. There are several features that are standard in one of these cardiograms. So first is the P wave. So it's going to start with the P wave that's just a little small bump, followed by a very jagged, sharp contraction that is going to consist of the QRS complex, with the Q and the S being those downward junctions, the R being the top. This then is going to go on to form a T wave before it goes through another cardiac cycle. Now, intervals, so from the beginning of the P wave to The beginning of the QRS complex is considered the PR interval. Sometimes it's hard to actually identify the Q, so that's why you get the R denotation there. And then the QT interval is from the beginning of the QRS complex to the end of the T wave. So that makes up all of that going there. Then you have this inner period before there's a contraction. The PR interval itself has a region that's known as the PR segment. That is the segment where the P wave ends, but the QRS complex has not yet began, so that's right there. The ST segment is going to be where the QRS complex has ended, but the T wave has not yet started. And then the QRS complex that I've been referring to is this space right here. All right, so how does the EKG relate to the cardiac cycle and what is going on during contraction? Well, if we start here, we're going to see the P wave first is going to coincide with atrial depolarization. So you can see the depolarization of the atria is happening here as the electrical signal is moving away from the SA node down through the internodal pathways. As it moves to the AV node, it's completing its pathway, and ultimately you end up in the PR interval where you have atrial contraction. Atrial contraction then is going to be followed with the QRS complex. This represents ventricular depolarization, but also happening is atrial repolarization. You don't actually see atrial repolarization. It's hidden by the QRS complex, which is mainly based on the ventricular depolarization, but you do have the atria repolarizing as the ventricles are depolarizing. The ventricles will continue to depolarize until they reach this base here, and then it will go through ventricular contraction. This ventricular contraction is going to move up and correspond to the ST interval. The ventricular repolarization then, where the ventricle, the resting potential is returning back to the normal point, that is going to be represented by this T wave here, and then it'll repeat itself for another cycle. All right, so there are a number of things that an EKG can tell you, and these can be very important as they can be significant indicators of something that's going wrong with the heart. So down here you have your normal EKG. This is what generally you are looking for. If you get one of these other ones, that's indicating that something is wrong. What could be wrong could be something like an arrhythmia, which is an irregular heart rhythm. You can have fibrillations, so rapid and irregular or out of sync heart contractions. This happens when the rhythm of the SA node is disrupted by rapid activity elsewhere in the heart. You may have heard of a defibrillator. So defibrillation, what it is doing, it's not really trying to restart the heart. So when you see people trying to start a stopped heart by putting a defibrillator on it, that's not what that does. What it's trying to do is reset the heart so that it is twitching at the normal polarization rates. The SA node is functioning normally, so you're resetting it for the SA node. You may have heard, or you may hear someone refer to an ectopic focus. This is when you have a pacemaker in the heart that's something besides the SA node. This can lead to extrasystole, which is premature ventricular contraction before the SA node initiates its contraction. You can get this if you've had too much caffeine, nicotine, and other things can cause it as well. And then you may have heard of a heart block. This is when all or some of the impulses are being blocked when, so it's some or all of the impulses fail to get through the AV bundle. So the ventricles are going to start beating at their intrinsic rate, which is way too slow for adequate circulation. This is when an artificial pacemaker will need to be implanted to recouple the atria from the ventricles. So as I mentioned, this is normal down here. Up here, you have a first-degree partial heart block. So if you look at this, you'll notice that you have your T and P waves on some of them, but for some of them, you have a P wave that's not followed by a QRS complex, but by another P wave. So about half the P waves are going to be followed by the QRS complex and the T wave, and half of them are not. So that represents a first degree or partial heart block. Atrial fibrillation, so this is the abnormal electrical pattern that happens prior to the QRS complexes. So you can see the QRS is this big jump in the EKG. The frequency between the EKG or between the QRS is also going to be varied and generally increased, and you don't have that characteristic P wave that is going to start it off. With ventricular tachycardia, you're going to have an unusual shape to the QRS complex. This is especially evident when you look at the S component. So here, your Q, R, and then your S, you would expect to just go down a little bit, but it goes way down before it comes back up. So that represents ventricular tachycardia. Tachy, that is referring to a fast heart rate. So the ventricular tachycardia is saying that the ventricles are contracting faster than what they normally would be. With ventricular fibrillation, you're going to have a total lack of normal electrical activity. So it's just going and moving really fast up and down. You don't have a normal pattern that you would hope to see. And then finally, in a third degree or complete block, you're going to have some of the impulses that are initiated by the SA node don't actually reach the AV node. So you're going to have cases where, you have this and then it's not going to be followed by the QRS complex. And so you have the QRS complex being very infrequent with this. And this can be very dangerous because then your heart's not beating at a rate that is able to sustain your normal blood circulation. All right, so this leads us to the cardiac cycle. So the cardiac cycle is going to be the complete sequence from atrial contraction to ventricular contraction and ventricular relaxation. Atrial relaxation also occurs, but that is going to overlap with ventricular contraction. So what we're going to see here is one complete cycle each time the heart beats. You've heard the terms systole and diastole. Systole is the period of contraction that the heart undergoes while it pumps blood into the circulation. So pumping blood during contraction is systole. Diastole is the period of relaxation that occurs when the chambers are filling with blood. All right, so this cardiac cycle is going to start with the atrial contraction. Atrial contraction, recall, is associated with the PR segment when you have the initial movement into the ventricles. That is going to push the blood back into these. That is going to be where the QRS complex is happening, where you're having depolarization. Now, notice you have isovolumic or isovolumetric contraction initially. This is because these are contracting, but it's not actually shrinking in volume because they haven't outperformed the pressure of the valve. So it's preventing the blood from actually moving into those areas. So ventricular contraction then is going to actually push the blood into the pulmonary trunk and the aorta. That is ventricular ejection because you're ejecting the blood at that point. And then you're going to have isovolumetric relaxation. This is when the blood is going to flow backwards, and that is going to close the semilunar and the pulmonary semilunar and the aortic semilunar valves. The ventricular filling is then going to occur as you start to, so this is relaxing, but the atrioventricular valves are still closed. So it's isovolumetric because the volume of this has not changed and no blood can flow into there. Then ventricular filling, that is when the relaxation has occurred to such a point that the valves are opening, the AV valves are opening and allowing blood to flow in there. So notice that the contraction of the atria, generally blood is going to be flowing in there during all this time. It's only when the blood contracts initially that blood is flowing from in one direction I guess blood is always flowing into the atria. You're having it pushed into the ventricle at that specific point. All right, so looking at how this goes, atrial diastole, that is represented at the beginning until you hit about midway through the P wave. Then the P wave and really the end of it, you're going to have systole occur. The ventricular diastole is going to overlap with the atrial systole. It's going to end pretty much in the middle of the QRS complex. And then here you're going to have ventricular systole occur at the end of the QRS complex, or really from the S to the beginning of the T segment, and even a little bit beyond that when it occurs. All this time here, you have atrial diastole, and all this time here, you have ventricular diastole. All right, so osculation. That is when you actually listen to the heart using a tool known as a stethoscope. The heart, listening to it can provide a simple but very effective diagnostic tool that allows us to determine what is going on with the heart. Normally you hear two heart sounds. One is the S1 sound, that is the lub. That represents the closure of the AV valves. That is what actually causes it, and it's going to occur during ventricular contraction. So you can see that ventricular pressure is going up, as is aortic pressure during that first sound. And then the S2 dub, that is caused by the closure of the semilunar valves. So it's the blood flowing back into the semilunar valves. This is occurring during ventricular diastole. You can also sometimes hear an S3. So in both of these cases, it's due to turbulence of the blood. S3 is another one. It's not exactly clear what causes it, and it is extremely rare in adults, but you can sometimes hear it in children. Maybe due to the blood flowing into the atria or blood sloshing in the ventricles. It is normal in children, athletes, and pregnant individuals. There are a few types of unusual types of contraction. If you have S1 plus S2 and S3, that may be indicative of congestive heart failure. So this is something that's known as the Kentucky Gallop rhythm. So you can think of where you have those three things happening in sequence. That is going to generally indicate a issue in older adults. And then you may have heard of heart murmurs. Heart murmurs are defined as unusual sounds due to the turbulent blood flow. This can indicate several problems such as valve stenosis, valve regurgitation, certain septal defects, and can also happen in increased or flow states, like you might have with anemia. All right. Finally, this brings us to cardiac output. So cardiac output, or CO, is the amount of blood pumped by each ventricle in 1 minute. It's determined by two factors. One is heart rate, that is generally referenced in beats per minute, and stroke volume, which is the blood pumped per heartbeat. The calculation is you multiply those two factors together. Now, using typical values, so if the stroke volume is about 70 milliliters and the heart rate is about 75 beats per minute, that produces about 5.25 liters per minute, but it can range anywhere from 4 to 8 liters per minute as a normal range. All right, so heart rate. The average resting heart rate is about 75 beats per minute, but normal is considered anywhere from 60 to 100 beats per minute. There are a number of factors that can affect heart rate. One is autonomic innervation. So this is going to be something that can really affect it very fast and very rapidly. Hormones can also do it, but that is going to be less rapid in the change. And then fitness levels and age can affect your heart rate as well, but that is not something that you can change very quickly. So we'll focus on autonomic innervation when we talk about what affects the heart rate. All right, stroke volume itself is a factor of two different components. One is the EDV, or end diastolic volume. That is the blood in the ventricle at the end of filling, so how much blood got into the ventricle. And the ESV, that is your end systolic volume. That's the blood remaining after contraction. So it's basically saying how much blood got into your heart and how much left of it. That is what your stroke volume. You can measure this using an electrocardiogram. The normal range for adults is generally between 55 to 100 milliliters, with the average being right around about 70 milliliters. So a number of factors can affect the stroke volume, things like the size of your heart, how fit you are, males versus females, partly because that is going to affect the heart size in itself. Contractility, the duration of the contraction, the preload and the afterload. Of these, contractility, preload, and afterload are the most important. So preload is the degree to which the cardiac muscle cells are stretched just before they contract. The contractility is the contractile strength achieved at a given muscle length. And the afterload is the pressure that the ventricles must overcome to eject the blood. All right, so looking at what can affect heart rate, you have parasympathetic activity and sympathetic activity. Parasympathetic activity is generally going to be mediated via the vagus nerve. So the vagus nerve is cranial nerve 10. It is going to release acetylcholine, or ACH. This has the effect of slowing depolarization of the SA node. So this is going to be what predominates at rest, keeping heart rate at around 60 to 80 beats per minute instead of the slightly faster intrinsic rate of the SA node. So you can think of this as the brakes. So this is going to put a brake on the heart rate. Sympathetic activity then is going to do the opposite. So this is going to be nerves that go to the heart. They are going to release norepinephrine. At the terminals, the norepinephrine is going to increase the SA node firing rate, so it increases the rate at which the SA node fires. That has the effect of increasing the conduction speed through the AV node and will affect contractility, which then affects the stroke volume as well. This is generally your stress, exercise, innervation that's going to predominate. It can also be the result of hypotension. So if parasympathetic activity is the brakes, then the sympathetic activity is going to be the accelerator for the heart. All right, looking at factors that affect stroke volume, the first thing we're going to look at is the preload. So things that will affect preload, predominantly it's going to be dominated by venous return. Generally, the key idea here is that the heart can only pump what it receives. So the more blood that it gets via venous return, the more that it's going to have. So the filling time, this is largely determined by the heart rate. So a slower heart rate is going to give it more filling time, which will infect the filling time. Now, paradoxically, if it's too fast, that is going to significantly decrease the stroke volume. So that is important because you think, okay, you want blood going through your heart, but if you make your heart beat faster than what it's able to actually allow for the blood flow to go in there, that's going to be counterproductive. So preload, then part of the reason venous return is going to contribute to this has to do with the increased stretch of the muscle. So this is going to be why venous return increases the stroke volume without changing the contractility, because increased stretch of the cardiac muscle increases the force of contraction. All right, sympathetic stimulation is also going to increase cavity. So this is mediated primarily through norepinephrine. So norepinephrine is going to increase calcium influx, which will lead to stronger contractions. So this is going to ultimately decrease the ESV, the end systolic volume, meaning that the heart is going to empty more completely. Now, we're only focusing on sympathetic activity here. Parasympathetic activity can also affect contractility, but this is mainly occurring in the atria, and it's very minimal in the effects that it could have. So epinephrine, thyroid hormone, and glucagon, those hormones can affect contractility as well. So that was thyroid hormone, glucagon, and epinephrine that can affect that. And then vasodilation or vasoconstriction can affect afterload. The main concern here is actually going to be the vasoconstriction, which is going to occur when you have hypertension. So typically your blood pressure is going to be fairly stable in the aorta. You're not going to have a large change in the vasoconstriction of the aorta. So that's not going to be something that it affects, but afterload can be significantly affected by hypertension. So that can lead to large changes in the end systolic volume because it's reducing the pressure that it has to fight. So vasodilation is having the effect of decreasing afterload, while vasoconstriction would increase it. And if you increase afterload, then your end systolic volume is going to increase, and that would ultimately affect your stroke volume negatively, since that means you're left with more blood at the beginning than the end. So that is how the factors affecting stroke volume and the factors affecting heart rate work together to ultimately determine your cardiac output.